If you remember just these concepts during your intermediate exam or in a clinical setting, you'll save marks and possibly a limb. Let's run through the highest yield orthopedics topics you must know. I go by the name Dr. Welly, and the following topics should be second nature for anyone in orthopedics practice. The first topic that we tackle on this series is compartment syndrome. Whenever confronted with a case of compartment syndrome, always think pain out of proportion. This is the earliest and most important sign. Other signs include pain on passive stretch, but remember, do not fall for the pulses trap. This is because normal pulses do not exclude the possibility of compartment syndrome. In summary, the hallmark of compartment syndrome is pain out of proportion to the injury and pain on passive stretch of the affected muscles. The gold standard for diagnosis is pressure measurement using the Whiteside's method, which accurately assesses compartment pressures. Because compartment syndrome is a surgical emergency, clinical signs may be unreliable. Hence, measuring pressures can save a limb. Understanding how to measure compartment pressures using the Whiteside method is essential for candidates preparing for intermediate exams. If delta pressure is less than 30, it warrants an immediate fasciotomy. The 6 Ps are late signs. These include pain, pallor, pulselessness, paralysis, paresthesia, poikilothermia. The next topic of discussion in this series is that of managing compound fractures. The approach to open fracture is systematic. This is because there is a high risk of infection and complications. It is therefore important for a clinician to follow a clear, practical, step-by-step approach when managing these patients. Before attending to the destructing injury, one needs to do a primary survey, ensuring they follow the ATLS principles. These principles involve attending to injuries in the order of their priorities. These include protecting the airway, and with that, make sure there is cervical spine protection, ensure adequate breathing, confirm adequate circulation, and if obvious bleeding is noted, then control bleeding immediately. Manage disability. This involves checking the patient's neurological status. Full exposure of the patient is also vital at this stage of the management. Important to note is that life-threatening issues always take priority over the fracture. After the hemodynamic stability of the patient is confirmed and life-threatening injuries managed, the next step in the management of compound fractures includes initial limb assessment. Carefully assess the injured limb by inspecting the wound size, contamination, and bone exposure. Palpate for tenderness and look for deformities. Examine the neurovascular status by assessing pulses distal to the injury. Check for capillary refill, sensation, and motor function. Document this before and after any intervention. Early intervention involves the following immediate management, which is critical in preventing infection. 1. Controlling bleeding. 2. Covering wounds with sterile saline-soaked dressing. 3. Immobilizing the limb with splints. And 4. Avoiding repeated wound probing. Antibiotics should be given urgently. One should start early IV antibiotics. Typically, one should give a first-generation cephalosporin like cefazolin. Additional aminoglycosides should be given for severe injuries. Penicillin should also be considered if there is contamination, for example in farmyard injuries, where there is Clostridium risk. Ideally, antibiotics should be given within 1 hour of injury. Also, give tetanus prophylaxis or give a tetanus toxoid booster plus minus tetanus immunoglobulin depending on vaccination status. The Gastillo-Anderson classification, which is predominantly an intraoperative classification, is commonly used to guide management of these patients. Almost all compound fractures need surgery as definitive management. Definitive surgical management constitutes an urgent irrigation and debridement, which includes removal of macroscopic dirt and devitalized tissue. Fracture stabilization is also critical at this stage of the management and can be achieved by 1. External fixation, which is common initially, or 2. Internal fixation, usually performed later or in selected cases. Wound management may be achieved either by delayed primary closure or a skin graft or even a flap if needed. It is important in these patients that we monitor for complications. Watch closely for infections such as osteomyelitis, compartment syndrome, non-union or malunion, and neurovascular compromise. Key principles to remember: early antibiotics save limbs. Do not delay surgery unnecessarily. Repeated neurovascular checks are essential and treat the patient and not just the fracture. The next topic commonly encountered in intermediate exams is that of cervical spine injuries and imaging modalities essential for diagnosis. The principles in polytrauma patients always say this. 1. Assume C-spine injury until proven otherwise. 2. Maintain immobilization throughout the assessment. And 3. Always follow ATLS protocol. The imaging modality of choice in diagnosing C-spine injuries is the CT scan, which is the gold standard. CT scan can be used to easily detect fractures, subluxations, and canal compromise. It is much more sensitive than the X-ray. X-rays are usually obsolete in trauma. One may miss up to 30 to 50% of injuries from X-ray review. For this reason, X-rays are only used as a primary diagnostic tool in resource-constrained environments where the CT scan is unavailable. Indications for CT are definitely an exam favorite. One should have a low threshold for CT in all trauma cases. Other indications for CT include high energy mechanism, neck pain or tenderness, neurological deficit, altered consciousness with a GCS less than 15, distracting injuries, and elderly patients. Key radiographic assessment involves assessing the alignment lines on lateral view X-ray. The lateral view C-spine X-ray is the most important in cases of trauma and often requested as part of trauma series X-rays. On this lateral view X-ray, the alignment lines that one must review are the anterior vertebral line depicted on the image by AV, the posterior vertebral line as labeled PV, and the spinolaminar line labeled SL. All these lines should be smooth and continuous. Any step off equates to instability or fracture. Additionally, one should use a systematic approach to check for A, which represents alignment, check if there is any loss of lordosis or any step-offs. B, which looks at the bones, assess for vertebral body fractures. C, which assesses cartilage, as noted by assessing disc spaces. Widening of the disc spaces imply ligamentous injuries. Last but not least, we assess D, which represents soft tissues. Any prevertebral swelling that is 7 mm or more at the level C2 or 22 mm or more at C6 is suspicious. When is it then warranted for one to request an MRI in C-spine injuries? It is important for one to consider ordering an MRI scan if the patient is having neurological deficits. Other indications include a suspected ligamentous injury, a normal CT but persistent symptoms, and a suspected cord injury. Common injuries that candidates must familiarize themselves with include the following: a Jefferson fracture, which is a C1 burst fracture, a Hangman's fracture, which is a C2 pars fracture, an odontoid fracture and facet dislocation, be it unifacet or bifacet dislocations. Under what conditions is it acceptable for a clinician to clear the C-spine clinically? If a patient presents to the emergency room fully awake and reports no neck pain on C-spine palpation plus all has full range of motion on the neck, then a clinician can clear the C-spine clinically. Otherwise, if any of the above-mentioned parameters is not met, then a CT scan is warranted. Do not forget that in an adequate C-spine lateral X-ray, one should be able to visualize the entire cervical spine, including the C7 and T1 junction. Another concept that is commonly tested in exams is the ability to recognize clinically the difference between septic arthritis, gout, tibia arthritis, as well as osteomyelitis. It is therefore vitally important to spend time on this to understand and know the differences. For the purposes of this lecture, especially for the South African setting, we shall focus on the differences between septic arthritis and TB arthritis. TB arthritis mainly occurs as a result of an infection by a Mycobacterium tuberculosis bacteria, while septic arthritis is commonly as a result of a Staphylococcus aureus infection. With TB arthritis, the onset is slow or insidious. It develops over weeks to months. Pain usually starts mild, then swelling and stiffness gradually increase. Systemic signs are subtle and may include low fever, night sweats, and weight loss. On the other hand, septic arthritis has an acute onset and usually more aggressive. Symptoms appear within hours to days. These include severe pain, a hot swollen joint, and high fever. Septic arthritis progresses rapidly. In TB arthritis, joint involvement is monoarticular, mainly affecting the hip or the knee joint. It is very notorious for affecting mainly weight-bearing joints. Septic arthritis is also usually of monoarticular distribution, and the most affected joint is usually the knee joint. If there is a clinical suspicion of either septic or TB arthritis, One would then proceed to do further investigations to confirm their clinical diagnosis. Lab investigations therefore form an integral part of this inquiry. With TB arthritis, one would note an elevated ESR as well as predominance of lymphocytes. Acid-fast bacilli may also be possibly cultured in the specimens. Conversely, septic arthritis labs would show neutrophilia and markedly elevated ESR and CRP. The offending organism may also appear on the cultured specimens, i.e., a positive culture. A Phemister triad, which consists of osteoporosis, erosions, and joint narrowing, may sometimes be seen in images taken to investigate TB arthritis. Images of septic arthritis, on the other hand, typically show rapid joint destruction. Furthermore, anti-TB therapy and possible surgery are the treatment modalities that have been documented to be effective in the treatment of TB arthritis. Septic arthritis requires emergency IV antibiotics plus arthrotomy and washout. To conclude this series, we will look at a quick overview of the ASIA classification used to assess patients with spinal cord injuries. If you've ever been confused by ASIA classification, the following explanation will make it stick. Think of A to E as moving from worst to best. A represents absent, meaning there is no motor, no sensory, and nothing below the injury. This denotes a complete spinal injury. B stands for barely, meaning there is preserved sensory function, but no motor function. The patient can feel, but can't move. C can easily be remembered to represent can't lift. This means that motor function exists, however, it is weak. More than half the muscles are grade 3 or less. Can't lift limbs against gravity. D, on the other hand, denotes does lift. Motor function is stronger, and more than half the muscles are more than grade 3, and can lift limbs against gravity. E means that everything is normal. Motor and sensory are all back to baseline. Memory hack: A equals absent and E equals excellent. Why does this classification matter? This scale tells you if a spinal cord injury is complete versus incomplete, which predicts recovery. Every concept you master is one mistake you prevent and one patient you save. This isn't just studying, this is responsibility. Subscribe and become the doctor people trust when it matters most.